jeopardizes myocardial contractility. After the brain death process, there's a school of thought in Europe that suggests that the heart's actually normal, but there's loss of the coronary perfusion pressure gradient that jeopardizes cardiac function. That being said, against the background of the endocrinopathy, really leads to a series of things that conspire to jeopardize left ventricular function. This is the reality of the patient that we're left to care for. Recent data from the West Coast looking specifically at subarachnoid hemorrhage and high-grade Hunt-Hess subarachnoid hemorrhage injuries suggests that, surprisingly, somewhere around 10 to 30% will have systolic impairment, diastolic impairment in about 3/4. And again, these are in survivors of subarachnoid hemorrhage. So these are patients who, when you do the first echo after brain death, these are survivors, and you can only extrapolate to suggest that the actual patients who died probably had much greater degree of neurocardiac axis abnormalities. But would not be at all surprising to see an abnormal cardiac echo. Would there be any suspicion in the 21-year-old who was playing basketball the day before, who got shot in the head, who had an ejection fraction of 20% the day before? Highly unlikely. So the neurocardiac axis has an enormous contribution that's very unrecognized. And in the survivors, a lot of this is a reversible process. A lot of the cardiac abnormalities seen with neurologic injury are reversible. In looking at estimates of blood flow with sestamibi scans or assessments of neuroadrenergic catecholamines with MIBIG scanning, if one has normal flow, but a global defect on, again, this is analogous to a pheochromocytoma scanning process looking at catecholamine uptake, with a global defect that occurs with subarachnoid hemorrhage, ejection fraction mean of about 43%. Hunt-Hess grade 5, 80% will have troponin release most early on. So it's critical to remember that many of these patients with cardiac dysfunction have antecedent damage before the brain death event. And the brain death event is an enormous catecholamine surge that profoundly jeopardizes myocardial function. So these things all conspire together to jeopardize heart function. The sympathetic surge, the antecedent injury, the speculative component of hormonal depletion, and a loss of coronary perfusion pressure gradients. This is somewhat of an ethically challenged study from France. And I think, as many of you see, probably around 2/3 of the patients have the autonomic surge that occurs, the response to increased intracranial pressure, maintaining perfusion pressure gradients, blood pressures of 260 over 140, heart rate of 130, lasts about an hour, hour and a half. This is incipient herniation. This is, again, as the downstream pressure goes up, you have to maintain a perfusion pressure gradient for flow. Well, this study in France actually treated that. They treated the compensatory response dominantly with esmolol. And I present this again not to underscore that this, in my view, would be a treatment option, but simply to underscore the magnitude of the cardiac dysfunction that's seen purely related to the catecholamine surge with brain death. If one looks at those patients that had no autonomic surge, compared to those who had an autonomic surge that was not treated, compared to those who had the autonomic surge that was treated, dramatic improvement in cardiac function after brain death and suitability for transplantation. So again, I'd underscore that I by no means would advocate doing this. I think this is incredibly ethically challenged in the context that we're aborting the compensatory mechanism to maintain cerebral blood flow. I think all of us have taken care of people who are on the cusp of herniation, who had the catecholamine surge, and able to either decrease the ICP or augment the mean arterial pressure to maintain flow, and these patients have survived. So doing this, in my mind, would be predicated upon some clairvoyance that we know who's going to survive and who's not going to survive. So I'd underscore that this really is more related to understanding the physiology and the implications that it has on the cardiac system. Similarly, as one looks at cardiac allograft vasculopathy, and these are the manifestations, very common when the explosive mode of brain death occurs, increased incidence of myointimal proliferation, coronary arteries, sudden death, need for revascularization. All these things are much more common. In a domino transplant where the heart's procured and there is no brain death, the reality is it's not seen very much at all. So again, you can't underestimate the magnitude of the contribution that brain death makes to cardiac function and the hemodynamic instability that ensues thereafter. So this is a very simple algorithm, nothing rocket science, incredibly straightforward, just core tenets, no significant medical management, simply standardizing process generated increased organ recovery and organs transplanted. USC, which has pioneered a lot of the donor management work, hypothesized that brain death complications would have no effect on the number of organs donated if these patients were aggressively managed. And again, this is as sick a cohort as any organ donor population that you or I would ever see. What they're able to show was that if one aggressively managed these patients, there was no significant effect of the complications or the number of organs procured. So it underscores that aggressive management, and again, ensuring that there's a continuum of management. Simply because the patient's brain dead, there ought not be an enormous hiatus away from any management until the care process may be terminated or stopped. It's aggressive management while the family has the opportunity to then define the donor opportunity. In this particular study, there were many side-off, spin-off effects, but the greatest benefit appeared to be abolition of the loss from cardiovascular collapse. They almost aborted the cardiovascular collapse, almost completely aborted it. If you look at the number of donors, they aggressively manage these patients. Historically, 25% of organ donors are lost during maintenance. With aggressive management, these patients can be maintained. Simply looking at the woman who was at the NIH with the brain tumor that was pregnant, was kept alive for how long? You can do it up to 6 weeks. The average time to death in the Japanese series, where brain death was not accepted until 2002, the time from brain death to somatic death, an average of 23 days. So with good support, these people can be maintained, and I'm not arguing that we ought to keep them supported for 23 days, but there is an intense period during that window where they can be supported to mitigate ischemia-reperfusion injury. This is the algorithm that we have that's predicated on stability assessments, and that requires echocardiograms, mean arterial pressure above 60, vasoactive requirement in any combination less than 10, and a urine output more than a C per hour per kilogram. If these thresholds are achieved with an EF that's reasonable, over 45%, that will be construed to be a stable donor, and then age would dictate the necessity of cardiac catheterization. As one sort of blows this component up and takes a little bit more look at it, if those stability thresholds are not achieved, I think the limited literature that exists might argue that some metric of volume, pump function, and impedance ought to be incorporated. Now, there is data in the donor literature to suggest pulmonary artery catheters, which has been unusual because there is no support in any other aspect of medicine that I'm aware of that delineates the use of PA catheters preferentially over anything else. And I think that the rationale for this comes from the comparative series that have looked at management. And if you have the Papworth England group who aggressively manages donors, has an anesthesia intensivist at the bedside, and goes through a 2-hour intense block of management, and compare that to a poor organ donor coordinator who's not a physician, who's managing a patient 100 miles away with a 16-gauge IV, over the phone, my guess is you're going to see enormous differences. So whether it's a PA cath, a LiDCO cardiac output, continuous stoximetry, CVPs, continuous echo Doppler, something to assess volume in the reservoir, hydraulic pump function, and the level of vascular impedance. This is the model that we torture our house staff with. It looks like an arcane engineering model, the circulation, but in reality it's an infinitely more simplistic way to look at circulatory mechanics rather than the traditional etiologic approach of this is cardiac, this is neuro, this must be sepsis, because nothing usually behaves itself consistently within all 3 domains of the hydraulic model. And this really exploits Guyton's original work in the 1950s, looking at volume in a venous capacitance reservoir that generates venous return to 2 hydraulic pumps linked in series. Because they're both in series, they can be conceptualized as a singular hydraulic pump, which then empties into an arterial impedance system. So any hemodynamic abnormality, whether it's sepsis, PE, hypovolemia, can be characterized and defined by the abnormalities in the hydraulic model. The organ donor tends to be intravascularly depleted, at least initially, in a low flow state, secondary to cardiac abnormalities, and usually vasodilated, almost uniformly vasodilated. So hypovolemia, cardiac dysfunction with some variability, but almost uniform vasodilatation. This is a complex and busy slide because taking care of donors is a complex and busy process. The reality is it's very controversial because there are no randomized controlled trials, absolutely none. So what I tell you is heuristics, it's anecdotal empiricism, it's 15, 16 years of taking care of dead people and reading dead people physiology and sort of at the bedside trying to define how best things respond. It's very compromised as well because the data on catecholamines are often derived from antecedent literature that uniformly and blanketly took on the vasopressors as sort of evil mongers of cardiac dysfunction. In reality, there's probably conventional doses of dopamine have immunomodulatory effects. So there's probably a lot of lack of attention early on paid to the underlying state of volume repletion in these patients, which has really handicapped this literature in terms of giving you absolute recommendations. The hypovolemia is usually manifest consequent to ICP treatment, whether it's fluid restriction, diuretics, or mannitol. Hyperglycemia and osmotic diuresis are common. DI is almost uniform. The poikithermic patient can't really conserve fluid. So all these things together conspire, particularly related to the ICP treatment, to present with an initially volume-depleted patient. Judicious fluid resuscitation is absolutely pivotal, and I say judicious because the single largest loss of lungs probably has to do with the fact that you've got distortion in the pressure-volume relationship in the left ventricle consequent to brain death. Small amount of volume generates a higher pressure against the background of an intense inflammatory response in the lungs, in a process almost indistinguishable from ARDS, precipitating extravascular lung water, fluid accumulation, cosmetically impairing the chest X-ray, and jeopardizing the PaO2. So all those things together really conspire to lose lungs, and it's judicious volume resuscitation. And managing these patients, I think, really requires the ability to adjudicate competing interests. The above the diaphragm transplanters would rather have the lungs exceedingly dry. The below the diaphragm transplanters would rather have the lungs, rather have the kidneys just gushy, moist, and augmenting flow. Keep in mind that two predictive indicators for improved kidney function that can be done in the ICU are a urine output more than 100 cc's per hour and a decay in the creatinine in the 6-hour window before procurement. That really requires volume. That's the antithesis of what the lung transplant program wants. They want it dry. The blacker the lung looks, the better it looks aerated. You can cosmetically fix that by drying somebody out. You can bump their tidal volume up to 15 cc's per kilogram, increase their mean airway pressure, and make it look really black. Doesn't necessarily help the lung, but it cosmetically improves it to the point where those lungs can be procured. So one strategy for this would be look at suitability of the lungs. If the lungs clearly are not suitable, if you can't use them, you got a big gunshot to the chest, you got massive aspiration, it's clear nobody's going to use those lungs. Well, then an overall strategy of a little bit more liberal fluid use, as long as one can maintain oxygen transport indices to the periphery, is probably appropriate. On the other hand, if you've got marginal lungs, and marginality in the lungs is two types. One is the antecedent marginality, which is the smokers where we breach the 20-pack year criteria. The other marginality is the ICU marginality, which is aspiration, pulmonary edema, and alveolar flooding and atelectasis. So that's the marginality that you can fix. The transplant surgeons have to figure out whether they want to accept the antecedent marginality. And in that population, a PA catheter or a CVP, some metric of volume and flow are absolutely needed, just like any other patient. And again, I don't come to work on Monday and decide, well, today's the day I'm going to box the kidneys and really dry the patient out so I can use less pressure on the ventilator. And on Tuesday, I don't come back and have this epiphany and say, well, you know, today I'm actually going to really wet the kidney out so I don't have to do dialysis and I'll just use more pressure on the ventilator. It's the same as any other management strategy that's titrated at optimal organ function from a unified perspective of the individual. Cardiac dysfunction and vasodilatation are almost uniformly coincident processes. A lot of things potentially can contribute to vasodilatation. The greatest is the loss of vasomotor tone secondary to the brain death event itself, and brain death significantly impairs cardiac contractility. I wish I could tell you what vasopressor to use. I'm not sure there's any confirming evidence in the literature that one's preferable to the other. My sense is that Care, as with any other patient, ought to be best titrated to the element in the hydraulic model that's impaired. If the problem is volume, the answer is volume. If the problem is inotropy, it's amps of inotropy. If the problem is vascular impedance, it's antagonizing the low impedance with constrictors. So it's mixing and matching the two together. If you don't have PA catheters in place, then in all likelihood, dopamine is sort of the one drug that fits most of the elements. A little bit of chronotropy, inotropy, and it constricts a little bit. It has immunomodulatory effects at the conventional doses we normally use, and that's what we usually start with. Catecholamines have received a lot of bad press, again, dominated by older literature because of the histopath findings, probably more related to inadequate flow and inadequate volume than anything else. A reliance on fluid, or the failure to use catecholamines, by definition, requires a reliance on fluid resuscitation. And that's probably the largest culprit that jeopardizes lung function. And it may further impair right ventricular function. There's other convincing arguments, and I think recent literature, particularly Schnelli's work out of the European Transplant Database, would suggest that catecholamines in conventional doses are clearly better for kidneys. The question is, are they better for heart? So the odds ratio is much better for kidneys than for hearts. So much like sepsis, I'm not sure that the magic bullet has well worked out at this point. So as one migrates down this pathway, if one places a PA cath or uses a LiDCO cardiac output and is unable to really achieve stability thresholds, in my view of it, this is where the hormonal concoction as rescue therapy is probably appropriate. This is an exceedingly contentious discussion. There is a lot of anecdotal literature, there's a lot of animal models, and many OPOs, many transplant centers have arbitrarily incorporated using hormonal cocktails up front, all donors all the time. Whether that's beneficial or not is uncertain. Whether it can have adverse effects, I think, is uncertain. I think it's highly unlikely. My guess is it doesn't hurt anybody, but does it really help anybody, I think, is the big question. If one looks at the limited amount of literature, it's a scattergram for the thyroid hormone. Probably 16 studies in the cardiothoracic literature looking at inotropic support of hearts in post-CABG shows it does have some inotropic support. It's probably a vasodilator as well. But the reality is, does it change outcomes? Certainly did in cardiothoracic. Does it really improve organ suitability in this population? Anecdotal reports say yes. Retrospective information says yes. But you can see the prospective, some, retrospective, others. It's an entire scattergram. So there really is no clear data to support it one way or the other. So I hold it and tend to advocate using it more in reserve. From a cardiac perspective, in the hearts that are not transplanted, logistically, we'd hope to fix that. You can't fix medical, but echocardiography, about a third of the hearts that aren't used are because of abnormal echocardiograms. So again, the 21-year-old playing basketball, is there any likelihood whatsoever that he had cardiac dysfunction the day before after he poured his gunshot to the head? Highly, highly unlikely. And what one sees that for each diminution in ejection fraction of 5%, the odds ratio of not using the heart is not good. So in studies, again, which are limited, that have compared areas of histopathologic correlation to areas of echocardiographic abnormality, there are none. They don't correlate. So it strongly supports an idea that much of the cardiac dysfunction, particularly shortly after the cardiac event, after brain death, is a reversible process, probably in at least 50% of the patients. So the ideal time to do your first echo certainly is not when the patient has a blood pressure of 60/40, hemoglobin of 4, potassium of 6.8, and a phosphorus of 0.4. The key is to get the patient tuned up, create the milieu where the heart will at least be as best functioning as can be, and then really, whether it's tincture of time or whether it's longitudinal management, see how cardiac function unfolds. Again, handicapped, as is most of this literature, by its retrospective nature. This is Cal CTEN looking at, again, a retrospective series of patients who had a low ejection fraction. Straightforward ICU management. In this study, none actually received thyroid hormone. A lot of corticosteroids, which intuitively makes sense, but the literature doesn't necessarily support that either. Well, they were able to show that in this group, significant number responded, identical outcomes to the group that had ideal cardiac function. So there is a recoverability in a significant number of these patients. And they were gracious enough to let me borrow one of their echoes. This comes from CTDN. And you can see whether this is aggressive ICU management and support of volume pressors, or whether it's simply tincture of time and letting a damaged heart actually recrudesce its function, is very uncertain. But tincture of time and watching and managing can make a big difference. Won't go into some of the subtleties about dobutamine stress viability studies. This was done in Japan, where they had brain dead patients and they subjected them to dobutamine viability studies. Those that actually were able to show contractility in 3 days recovered their cardiac function. So there are some predictive indices available. In terms of overall management, this is the Papworth England group study. These are their acceptable criteria. These are the criteria that didn't achieve threshold. They aggressively, optimally managed invasive monitoring. They're big believers in hormonal cocktails. 44 of the 52 hearts that never would have made it to the Igloo actually were procured, transplanted, and had outcomes indistinguishable from ideal hearts. So there's an enormous wastage at a societal level of the number of hearts that aren't used that could be placed in patients for want of aggressive management in the intensive care unit. From a pulmonary perspective, oftentimes the history is unknown. The causative event is almost uniformly associated with some abnormality in the gas-air interface in the lung itself. Mechanical ventilation has its own potential culpable problems, and brain death physiology has recently been recognized as having a major role in pulmonary process. I think historically the blast injury with capillary permeability, neurogenic pulmonary edema, has now been complemented by an intense inflammatory response. There's some suspicion that sympathetic alteration of permeability occurs as well, but it's recently been shown that there's a very, very intense inflammatory, a preclinical injury to the lung consequent to brain death. Fisher's group has pioneered this work, and in looking at IL-8, which is a chemoattractant factor for neutrophils, comparing that to lung cancer patients who had a wash and a sampling done, just profound levels of intensity of inflammation in non-traumatic. This is not polytrauma. These are isolated head injured, isolated brain bleed patients, not polytrauma. If one were to then speculate the intensity of the inflammatory response in the donors related to brain death, how does it then impact upon the recipient? That was the next logical step. So they looked at the intensity of the IL-8 expression and then looked at survivorship and functionality in the recipient. IL-8 correlated with the neutrophil infiltration, correlated with the early PFI2 ratio, correlated with early graft dysfunction, correlated with longitudinal outcome and mortality. So it strongly suggests that there is an intense inflammatory response, and the lungs aren't the only unique organ. This occurs in all organs, where there's preclinical injury. And in the future, the targeted strategies won't be to use a University of Wisconsin solution to then preserve tissue that's already damaged. It will be to attenuate this response in the donor, and that's what many of our labs are beginning to look at this point. You can see the PFI2 ratios, early graft dysfunction, and then mortality. So it suggests, again, very strongly that there's an intense inflammatory response. Many of you are familiar with the ideal lung criteria, which many have argued are very arbitrary and capricious, drawn up almost 20 years ago. How good are these criteria in differentiating lungs that are used and not used? Well, in Finer's study of lungs that were not used, again, this is an unfortunate series, but none of these lungs were used. Of the 47% via conventional criteria that were thought to be acceptable, 40% had significant disease. In those that were deemed unacceptable, 14% had only minor pulmonary abnormalities. So the conventional criteria really are not good at differentiating good and bad lungs. Similarly, in a large study that looked at histopath of donors compared to the regional donors, so no difference. They didn't sub-select a certain group. So I think you can actually take this relationship and exploit the relationship a bit. They found that about half of the lungs histopathologically were fine. Half the lungs were probably fine. Fisher's group did the exact same thing, looking at the intensity of the inflammatory response, and concluded that the current criteria are poor discriminators of pulmonary injury. So again, this underscores, as we look at marginal lungs, antecedent marginality is a transplant-centered decision, what breach you'll take with smoking. Marginality related to the ICU is in many instances fixable. And these are the acquired reversible processes that would occur that would then allow patients that historically weren't used to be transplanted. So again, I just would underscore, as we look at this baseline status, this is the key question the transplant pulmonologist and the transplant surgeon have to answer is what's the relative balance of death on the list versus the breach of these antecedents that exist in the lung. In terms of the ICU marginality, this is a study out of Australia looking at patients that historically were below the threshold criteria. And there's some that clearly are unsuitable, the gunshots to the chest, you've got the massive aspirations, but the other bunch, they subject it to aggressive intensive care unit pulmonary management, much like any other patient. Well, you can't fix everything, but half of them they fixed. And they were transplanted. Marginal constituted 57% of the aggregate donor group whose outcomes were indistinguishable from the ideal lungs. Indistinguishable from the ideal lungs. So much like the heart, it underscores that there's a lot of opportunity to then aggressively manage these patients in an intensive care unit environment. San Antonio recently published a study looking at education via the OPO staff, transplant pulmonologists, and establishing donor protocols and ensuring consent was obtained in all donors for lungs. This is their active management. Not a lot of rocket science. Pressure control ventilation 25 with a PEEP of 15 for 2 hours. And this was done in patients with a PFO2 ratio less than 300 or alveolar infiltrates. Switching to conventional ventilatory mode with a tidal volume of 10, PEEP of 5, minimizing crystalloids, diuresis, mitigating against aspiration, and bronchoscopy to evaluate the chest X-ray area of infiltrate. This is reasonably semi-routine management, save the arbitrary pressure control. Just operationally, the key thing to remember is those that were poor that became ideal, those that were poor that became extended. These were the absolute or criteria they used. These are what constituted extended criteria. So the ideal lung had all of the good absolutes and nothing from the extended criteria. The extended group had all the absolutes, and they had one or more, maybe been somebody with just a smoking history. And the poor didn't satisfy any of these, which are the requirements for transplantation. 75% of their donors were initially poor. 75% were initially poor. 50% actually were upgraded through that particular protocol and management to extended or ideal. 23% were actually transplanted, and 55% of all their transplants were from donors that were initially classified as poor. So in looking at the two periods, pre-management, post-management, number of potential donors in the post, 381. The consent went from 76 to 88. The actual donors went from 38 to 98. Lungs recovered, 63 to 167. Lungs transplanted, 53 to 121. So again, just dramatic improvements, much like the cardiac literature, with aggressive management in the intensive care unit. Conclude with just talking briefly about fluid and recognizing again that oftentimes there's diastolic cardiovascular impairment, precipitating fluid flux, extravascular lung water, and wet lungs, which is probably the single largest cause of loss of lungs in this population. And you can see with, this is not a randomized control, but it's a case-controlled series. CVP less than 6, target, takes a lot more fluid, change in the A gradient. And in this study, there was little discrepancy between the filling pressures on the left and right, probably due to diastolic impairment and rigidity of the heart. But a lot of it ends up in the lung. So it's judicious fluid resuscitation and volume. Lastly, if one looks at kidney, the biggest thing you can do is maintain good cardiovascular hemodynamics. Decay in the creatinine and a urine output more than 100 cc's per hour. These are the things that are associated that are amenable to change. A lot of things you can't fix, but these are two things that you can fix. And with livers, similarly, there are a lot of things that you can't really fix, but this is one that can be fixed. Ideally, the sodium should be less than 155, and I think we're moving in a direction with the recognition that glycogen depletion is one of the things that is involved in increasing the magnitude of the intensity of the ischemia reperfusion injury, beginning to feed gut feed donors during that process is a process in the evolution. So I'd conclude with that. Thank you very much for the opportunity. Hope I've left you with a sense that donor management really is an integral part of intensive care unit management, and it is truly the medical management of 6 to 8 other lives simultaneously that warrants the same level of intensity and the same level of integrative multidisciplinary care that we would apply to any other patient. I'd be happy to take any questions.